Okay, assalamu alaikum. This is a case where we are looking at impressions for a partial. Okay, why did you take the lower?
For recording the lower teeth.
I need a lower cast. Do I need to take all of the sulci in it? No. I need only the teeth. But still, I'm a bit meticulous, and I also always ask my students to take, even if it's for occlusion. I always tell my patients, take an excellent impression. Why? Because impressions talk about you. Okay? They talk about you when you do the perfect impression. Technicians will know this is a good doctor. Okay? So even if you're making it just you're using the impression material and you're using the tray, why not take a perfect impression? So what are the problems with this impression? You have a lot of bubbles, so you need squeezing the material on the walls of the rubber bowl before inserting it without any bubbles. Okay, you have a lot of bubbles. These are mixing bubbles. Okay, there's another way. There is something called an alginator, where it's an automatic mixing machine. It rotates on its own, and you place your spatula in a way, in an angle. You learn it, and it will squeeze out any remaining bubbles. Okay, this is another way to eliminate bubbles. The second thing is the lip trap. Do you see this lip trap?
Yeah.
Why does this happen?
Because you didn't stretch the lip before.
But many times I have many students where I tell them, you have a lip trap, and they say, I stretched the lip. Why did this happen? Because they stretched the lip after loading the tray and vertically on the teeth and seating it. We stretch the lip before seating. You might go inside the patient's mouth with the tray, but before going down vertically, before pressing vertically, I stretch the lip and then press on the teeth with the impression material. Okay? This will allow the excess material to go into the sulcus rather than trapping under the lip. Okay, and dragging. Because the lip will drag the material away. So you'll not have enough material to go inside the sulcus. You don't have a tongue trap, that's good. Okay, you recorded the lingual pouch area all around. Okay, and the lingual sulcus anteriorly. That's fine. The lingual pouch, not all of it, but we don't need it now. But in case you need it, you can extend by utility wax before taking the impression. Okay, so the lingual sulcus, the labial sulcus. How do I get a good labial sulcus on both the upper or lower? Simply, first of all, I move my tray before going and seating vertically. I move my tray away from the anterior teeth by 1 centimeter, for example. Then, when I begin pressing vertically, before pressing, I tell the patient, raise your tongue, and I stretch the lip, and then I begin pressing downwards. When I'm pressing downwards, many times I'm coming closer with the tray towards the teeth. But I have sufficient amount of material to go into the sulcus. Okay? It will squeeze into the sulcus. Now, this is the one of our concern. This is a case where we have anterior missing teeth, and we have posterior. Although this is a class, what, Kennedy?
Kennedy class two.
Class 2.
Yeah.
Class 2 has 1 space. Class 1 has 2 spaces. It's inverted. Class 1 has 2 spaces. Class 2 has 2. I know that you have the 8 extracted, but you're not going to replace it, صح?
Yeah.
So even though the 8, I don't consider it there, and I'm considering the anterior teeth, only this side. So it's considered the class 2, but I'll work as it's a class 4, because I have a long span anteriorly that is edentulous, and this patient also has a class 3, so I'm going to extend my teeth and my acrylic anteriorly a bit more for camouflage to compensate. This patient has a class 3 bone relationship, so I'm going to add a lot of material here to replace this tissue. This amount of material added will create it mechanically. I'll treat it as a class 4. I need posterior indirect retention. Okay, in my design. Even if it's a transitional partial, still I need the same biomechanics. So it's not only for chrome cobalt. When I'm thinking about retention, I'm thinking about indirect retention and so on. In the acrylic, the good thing here, I'm going to take the full depth and the full pose dam. I'm going to make a full pose dam here. Okay, I'm going to utilize this tuberosity area. So here, how I'm going to judge your impression, I need to make sure that you have recorded this correctly. I'm going to measure it by my finger and make sure if you've taken it correctly. If you have not, what you're going to do, you're going to repeat. Or do a special tray. Okay? Sometimes we're limited with our trays. So you might go with a special tray. Or I make you to repeat it and add utility wax here to build up this buccal pouch, because we're going to depend on it a lot for our indirect retention. Okay? Okay, these teeth are there in the impression. I have some drag here or an excess. Okay, now this is just excess material. So you have a bubble here. See the mixing bubbles? What are these bubbles? Are these bubbles from mixing?
How to know?
Do you think these are bubbles from mixing? They might be. This one might be, and this one might be. But the other small bubbles are not from mixing.
From the pellet.
From the pellet. What do we have in the pellet there?
Smoking.
He has nicotine stomatitis.
Yeah, nicotine.
But even nicotine stomatitis doesn't create these unless it's very prominent. Is it rough in the pellet? Do you feel it rough? Touch it. So she says that these pinpoint bubbles are nicotine stomatitis. Is it severe? Is it creating papillary hyperplasia? Do you see papillary hyperplasia? No, you don't see that papillary hyperplasia. If I have papillary hyperplasia, I will see it in the impression. But this is not papillary hyperplasia. What other things are these minor things? These are what? Minor salivary glands. What do they secrete? Saliva. What is the type of saliva they secrete? It's a bit thick. It's not like the lingua and the parotids. Okay, it's more serous. Those are more serous, more watery. These are a bit thick. So how do I avoid this? Either by making the patient wash his mouth forcefully and gurgle and with the water and move the water around in the mouth with the tongue and wiping it with the tongue, or before taking the impression, I take a small gauze and wipe it away. In some elderly patients, I could even see them. I could see the saliva. It's like small pebbles in place, made of mucin. So even when they wash their mouth, it doesn't go away. It's heavy, it's thick. So I need to make them wash and swish with the water in their mouth, and then I even can come with a gauze and remove them. Okay? So this is saliva excreted from minor salivary glands. It's not the gland itself. It's not papillary hyperplasia. Okay? So how to avoid this and make it smooth? By making the patient wash his mouth. This is a big bubble. This is a deficiency of material. Okay? You can place wax better. Yeah. This is another deficiency of the material. The occlusal surface of the teeth are okay. Do you see that the tray is showing through buccal surfaces? What does this mean?
There's deficiency in material.
Deficiency? No. This is the tray is small.
Yeah, but
I don't have lateral space beyond the teeth.
Yeah, the largest tray.
So you need but this is our largest tray. All of these recommend that we do a secondary tray. You are not aiming to do a secondary impression.
Yeah, because he cannot come,
He could not come. No, please do a secondary tray. Because all of these problems. This is our largest tray, and still it's small and it's hitting the teeth. I didn't take these teeth correctly buccally. Why do I need to take them correctly buccally? Because I need them for clasping. I needed them for retention. Do you think with this drag that happened, because once the tooth touches the tray, it will drag the material away. So the buccal surface is not captured correctly. Can I place a clasp over it? I will not know where the marginal gingiva correctly is. The material is not accurate buccally. So I need to take a secondary impression. Okay? If the patient could not come, if you have quick setting plaster, some of the labs have quick setting plaster. I pour this quickly by quick setting plaster and make my special tray light cured. 2 minutes, total up 10 minutes, 15 minutes, you will have a tray and come back to the patient. Yeah. Let the technician do it. By fast setting plaster. How do I create fast setting plaster? Either I have it ready, fast setting plaster mixes, or I add slurry water. Okay, so go quickly to the lab. Okay, let them pour it. Within 10-15 minutes, you have an afternoon clinic.
No.
Okay, we are still in the beginning of the clinic. So at the end, you will have a tray and you will do a secondary impression. Okay, thank you.